بس ننتظر الأخوة والأخوات يدخلوا حتى نبدأ الويبينار إن شاء الله. Okay, let's start. السلام عليكم ورحمة الله وبركاته جميعا. Okay, a couple of more minutes. We'll wait for more people to join. It's fine. Let's start. بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آل بيته الطيبين الطاهرين وصحبه المنتجبين. السلام عليكم جميعا حيثما كنتم ورحمة الله وبركاته. It is with great pleasure and honor that I welcome you all to today's educational session hosted by the Oman Diabetes Association. We are proud to come together once again in the spirit of collaboration, knowledge sharing, and clinical excellence. Today, we turn our focus to a topic of growing importance: renal disease in children with diabetes. As pediatric healthcare providers, we are witnessing a rise not only in the prevalence of childhood diabetes, but also in its long-term complications. Among the most serious of these is diabetic kidney disease, a silent yet progressive threat that demands our proactive attention. We are fortunate to have with us an expert, a local expert, and frontline practitioner who will enrich today's session with clinical insights, real-world experiences, and research-backed practices. Your engagement and questions will make this session even more impactful, so I encourage you to participate fully. Our guest for tonight's event is Dr. Thuraya bint Ahmed Saeed Al-Sulaimi. She's pediatric nephrologist consultant. Dr. Thuraya graduated from Sultan Qaboos University back in October 2008. She completed 4 years in a child health residency program, pediatric program, under the umbrella of Oman Medical Specialties Board. And then she completed her fellowship program in pediatric nephrology at Calgary University in Canada. During her journey, she completed the Arab Board and then Diploma in Child Health, followed by membership Royal College on Pediatric and Child Health in 2013. On her return to Oman in 2018, she became a consultant in pediatric nephrology, and she led the pediatric nephrology unit, starting the service from scratch at Nizwa Hospital, and she established the pediatric, peritoneal, and hemodialysis services in Nizwa Hospital and Dakhiliya. So without further delay, I would like to welcome you again on behalf of the Oman Diabetes Association, and I thank each of you for being here, for your dedication to child health, and for your commitment to continuous learning. Together, we can make a meaningful difference. And so thank you very much. And the floor is yours, Dr. Threya. Let's begin.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Dr. Hussein, for your nice introduction. And also, I would like to thank the Oman Diabetic Association for inviting me to do this lecture today. It is, as rightly introduced for the topic today, it is an important topic, and it is actually gaining more attention in the world and in the pediatric clinical settings and among the pediatric nephrologists. I actually enjoyed myself preparing for this topic. So today we are going to talk about renal diseases in children with diabetes, what is to be learned. Here are my objectives. So I'm going to go through the recent updates to the diagnosis of diabetic kidney disease in children and adolescents. We'll talk about kidney disease in monogenic forms of diabetes. We'll talk about acute kidney injuries in diabetic patients. And then we'll go through the management, addressing the risk factors that promote the development of diabetic kidney diseases. Finally, we'll talk about non-diabetic nephropathy in diabetic patients. And to make our session today more relevant to our daily practice, I prepared 3 cases, clinical cases from my clinic, all related to these topics that we are going to, objectives that we are going to discuss today. So my first case, this is now he is a 10 years old child. He was diagnosed to have neonatal diabetes with a confirmed genetic mutation. Throughout his follow-up, there was no significant microalbuminuria or hematuria. However, he suffered poor glycemic control with high glycated hemoglobin throughout. It is above the recommended range to define a controlled patient. His current creatinine level range between 90 to 80, which is at stage 2 CKD. Are my slides clear to you? Everybody?
Yes, Dr. Threya, very clear, yes.
So in September 2024, he underwent renal biopsy, which revealed features of diabetic nephropathy. So renal disease, as you rightly say, Dr. Hussein, is a significant complication in children with diabetes. And the diabetes in childhood led to significant damage at the kidney levels. It starts from the stage of acute kidney injury, and then with time, patient progress to the development of the diabetic kidney diseases and progress to end stage kidney disease if not managed effectively. The gain of attention for this particular complication, diabetic kidney disease, is partly because of the increasing prevalence of diabetes in children worldwide, especially type 2 diabetes, and it is partly associated with the increase in the prevalence of obesity in children. Another factor that contributes to the development of diabetic kidney diseases in diabetic children is the aggressive natures of the disease in children and adolescents that is characterized by more rapid B-cell decline, faster development, and progression of diabetes-related complication. And also we observe that these young, the pediatric patient and the adolescent, they do have lower responsiveness to treatment when we compare them to the adult population. If we talk about the terminology, previously we term the diabetes, the renal complication related to diabetes, we term it as diabetic nephropathy, which is historically defined as the clinical presence of albuminuria accompanied by retinopathy in patients with diabetes. However, the term now is actually replaced by the diabetic kidney disease, which is a clinical diagnosis that indicate the presence of albuminuria with or. So it is not necessarily albuminuria by itself is enough to make the diagnosis of diabetic kidney disease. However, either one of them, either albuminuria or decreased estimated GFR in a patient with diabetes, this will make the clinical diagnosis of diabetic kidney disease. And we are living now in the world of precise medicine. And now even some authors use the term of diabetes and chronic kidney disease to describe this type of complication, diabetes-related complication. For example, the KDIGO guidelines use this term to describe patients with diabetes and chronic kidney disease when their renal biopsy is not available, which is really often. So we are not tending to do renal biopsy in most of patients with diabetic, especially in adulthood. So diabetic kidney disease is a complex and heterogeneous disease. Usually it starts with hyperglycemia that induces cellular injury at the level of the kidneys. This will lead to the mesangial expansion, hypercellularity, glomerulosclerosis, and then tubulointerstitial fibrosis and inflammation. These injuries will manifest in a patient with albuminuria that varies in severity according to the severity of the damage. And patient also might have initial high to normal GFR that progress with time to lower and end-stage kidney disease. And as patient progress and the disease progress, patient will develop further complications like hypertension and cardiovascular disease. And these all contribute to the final, morbidity and mortality risk for these patients. Here again, this diagram showing the pathogenesis, but I just bring it here to highlight it is not only the hyperglycemia that contribute to the pathogenesis and the development of diabetic kidney disease in this patient. There is other contributing factors that make one patient is at more risk to develop this complication compared to other patients, which include genetic background, obesity, and circulatory inflammatory cells. If we ended up doing a biopsy for patients with suspected diabetic nephropathy, this is what we are going to see. The picture A is showing a nice glomerulus. Picture B showing a glomerulus with diffuse mesangial expansion, and I don't know if you can see the arrow, diffuse mesangial expansion and mesangial cell proliferation that progress with time to end up with the obsolescent glomeruli as we see in picture F. That was at the glomerular level. What happened in the renal cortex also, the picture A is now showing a nice back-to-back tubules. However, with the hyperglycemia and the induced injury, patient will start developing the thickening of the tubular basement membrane, and then at the endothelial levels, there will be accumulation of the hyaline material and causing the collapsing and compromise of the lumen of the vessels, and at the end patient with tubular interstitial fibrosis and atrophy. As we said, or even Dr. Hussein said, the prevalence of diabetic kidney disease are increasing because of the increase in the prevalence of diabetes itself. For example, in the period between 2002 and 2015, the annual percentage change of type 1 diabetes is around 2% per year. And the annual percentage change for type 2 diabetes up to almost approximately 5%. So which is a significant change per year. And we do see like more rise according to the ethnic and racial group of patients. And as we said before, for type 2 diabetes, the prevalence of it is increasing as the prevalence of obesity increases. Here, this is a recent data from US statistics of prevalence of type 1 and type 2 disease. The gray bar, if you could see, is representing the year of 2017. And across all ethnic groups, in 2017, there was an observed increased prevalence of both type 1 and type 2 diabetes. So if we talk specifically about the prevalence of diabetic kidney disease among patients with diabetes, as we said, because probably diabetes in children and adolescents are more aggressive in nature. And this led to the increased risk, increased prevalence of diabetic kidney disease in children and adolescents, rising from 1.16% to 3.4, almost 4% between the years of 2002 and 2013. And then in patients, so that patients with type 2 diabetes are proved to be at higher risk of diabetic kidney diseases, and their risk of developing kidney disease is 23-fold higher than their compared age-matched controls. And their risk for requirement of for requirement of dialysis is about 39-fold higher than normal population, age-matched population. So as we said, the component of diabetic kidney disease is albuminuria and reduction in GFR. So we observed that moderately increased albuminuria among adolescents with type 2 diabetes is occurring between 6 to 22% at time of presentation. For example, in today's studies, the increased albuminuria was present in 6.3% at baseline. Yani 6.3% of these participants were identified to have albuminuria at baseline, and then it increased, this percentage increased to 13.4% after 5 years of follow-up. They identified in this today trial that poor glycemic control was associated with a higher risk of albuminuria. And in the long-term follow-up, the cumulative incidence of diabetic kidney disease was 55% at 15 years after diagnosis of type 2 diabetes. So, which is like, we imagine we are like diagnosing our patient at 5 years of age with diabetes. But however, this is actually so just to correct myself, this is for type 2 diabetes. Not most of our patients are type 1, unfortunately, so far. The incidence and progression of nephropathy in youth with type 2 diabetes is greater, as we said before, in type 2 compared to type 1. Even this was seen and observed in this trial after they adjust for age, disease duration, glycemic control, and obesity. So what are the clinical criteria to diagnose diabetic kidney disease? We need to have a patient with persistent albuminuria or persistent decrease in glomerular filtration rate. And we need also to have a patient with a long duration of diabetes. This is for, or established diabetic retinopathy. This is for type 1 diabetes, and 5 years actually duration of type 1 diabetes is enough duration for a patient to develop moderate proteinuria with a mild reduction in GFR, especially if patients have a poor glycemic control. However, for type 2 diabetes, diabetic kidney disease can present right away from the time of diagnosis. That's why the guidelines, as we will see later, recommend the screening for type 2 diabetes for albuminuria at time of presentation and at time of diagnosis. No need to wait. So if we talk more about albuminuria, so increases in urinary albumin excretion rate is classically described as an earlier sign of diabetic kidney disease. However, not in all cases, and that was typical in the case, if you remember, the first case that I have presented, who never have, the patient till now did not have a significant actually albuminuria. And his albumin excretion rate was at just before we proceed for kidney biopsy for him was just 12. So it was in the category 12 milligram per day. So it is in the category of normal to mildly increased. So this is like giving us where we are standing now. Like we do have our screening for this patient is limited to the albuminuria, which is we were like till now we are looking at it as an early sign, but it is not in every patient. Reduction in GFR is actually a later stage. So we actually aim to diagnose and detect these patients with diabetic kidney disease as early as possible to prevent the reduction in GFR. Unfortunately, these type of markers so far are not available. So when we categorize the albuminuria and proteinuria, we either send albumin excretion rate for 24-hour collection for albumin or protein. So if it is less than 30 milligram per day of albumin, this is in the category of normal to mild increase. If the patient have albuminuria of 30 to 20 to almost 300 milligram per day of albumin, this means patient is having moderate increase in the albuminuria. If the albumin excretion rate is more than 300 milligram per day, so this is a severely increased albumin excretion rate. We could do also, and these are like, as you can see, the values for protein to creatinine ratio. It is not necessary to do, and this is the more practical, and what we do in more of the follow-ups is the spot urine albumin to creatinine ratio. And if it is less than 30, so if patient is we consider the patient having normal to mild increase in the albuminuria. If it is between 150 to 500, so that is moderately increased. More than 500 is actually severely increased. We could also utilize the urine dipsticks. So mild to moderate should be negative to trace. Moderately trace to 1+. So this is why like it is not a preferred modality to screen patient with for albuminuria. So albuminuria severity is important still, even if it is not enough. But however, it is still important, and all guidelines recommend for it. So it reflects the disease spectrum from mild to severe, and the severity of albuminuria increase the risk. It is known that the albuminuria severity increase the risk of cardiovascular disease and mortality, and also it is associated with an increased risk of progression of chronic kidney disease. So that's why pediatric guidelines recommend annual screening for detection of albuminuria. We recommend to send urine sample collected in the morning, first voiding urine. The screening for type 1 diabetes should begin starting at puberty or 10 years of age, whichever is earlier, beginning 5 years after type 1 diabetes diagnosis. However, for type 2 diabetes, it is at time of diagnosis, we should send the urine screening and then annual follow-up. This is from the International Society of Pediatric and Adolescent Diabetes. So guidelines. So all patients with type 2 diabetes should be screened annually for albuminuria. And as we said, the most convenient method to do is for screening is the urine albumin to creatinine ratio. Initial testing for type 2 diabetes should be performed at diagnosis. And then also these patients should do at least annual check for their renal function test and calculate their estimated GFR. And if we identified a patient with urine albumin creatinine ratio of more than 30 milligram per gram, they should repeat the screening in at least 2 occasions during the 3 to 6 month follow-up period, because we could see false positive results just because of a urinary tract infection, febrile illness, or, for example, menstruation. And if we find a high urine protein to creatinine ratio, here it is more important to ask for an early or first morning void, just to eliminate the chance for a false positive result. And if we confirm the presence of moderate albuminuria, and if the patient is having high blood pressure, it is an indication to start angiotensin converting enzyme inhibitors or angiotensin converting receptor blockers to normalize their blood pressure. However, if the patient is having a severe albuminuria of more than 300 milligram per milligram, even if the blood pressure is normal, this is by itself is an indication to start medication with AC inhibitors. For patient who has hypertension and significant proteinuria, they should be referred, of course, to the nephrologist, and we should consider other causes, non-diabetic form of diseases, of non-diabetic diseases that cause CKD in a diabetic patient. And if we diagnose a patient with albuminuria, again, it's still the recommendation is to go for annual screening of renal function, at least is annual. So for the GFR, usually patient at the initial presentation with diabetic kidney disease, they will have what we call it hyperfiltration. And it is reported in 25 to 40% of diabetic youth with diabetes. We defined hyperfiltration as a GFR of 120 to 150 ml per minute per 1.73 meters square, or more than 2 standard deviation above the mean for normal GFR. Hyperfiltration is believed to be a strong predictor of subsequent GFR loss. And so we don't become very happy if we see their creatinine level even far below the normal. This indicates there is a hyperfiltration, and it is maybe a predictor that patients will subsequently have a reduction in GFR and progression of DKD. And this association between hyperfiltration and the loss of GFR have been observed in both types of diabetes. We usually, as we said, monitor renal function test and calculate GFR according to the equation we estimated. However, in children with a GFR less than 60, there is what we call it kidney failure risk equation, and it includes 4 variables for kidney failure: age, sex, albumin excretion rate, and eGFR. And by doing this calculation, and we can predict the 1 to 5 year kidney failure risk. However, fortunately, we really rarely see a patient with diabetes and kidney disease just related to diabetes with a GFR of less than 60. So as we said before, we really need novel biomarkers that help us to detect this type of patient in an earlier stage. So far, there is no available biomarkers that is better than proteinuria, and it is being used for routine clinical practice in either adult or pediatric population. In adult studies, they observe, for example, serum tumor necrotic factor receptor 1 and TNFR2 has been found to be associated with early structural change of DKD and also associated with DKD progression. However, it is still not in clinical use. So now we'll move to talk about acute kidney injury, which is now also gaining more attention as a contributing factor to DKD. So AKI is not like one-time episode, an event. No, it have its consequences and may contribute and lead to the development and progression to DKD in the future. And as we see in our clinical practice, AKI is common consequences of diabetic ketoacidosis. It occurs in about 40 to 60% of patients with DKA. So, I mean, AKI occur in up to 60% of patients who present with DKA. In adults, they found that we have studies that prove that AKI is associated with a greater risk of developing DKD, and this risk increases with each AKI episodes. They compare the adults with DKA who never experienced AKI and patients with DKA and recurrent AKI. They found that patients with DKA and recurrent AKI have more rapid progression to DKD and have higher long-term mortality. The rate of CKD progression is proportionate to the severity of DKA-associated AKI. So to the severity of AKI in relation to the DKA. However, in children, data regarding the association between diabetic ketoacidosis associated AKI and diabetic kidney disease progression are not available yet. However, we do know that AKI and diabetic ketoacidosis co-occurrence can affect long-term management and outcome. And this it means, like, for example, the time to resolution of metabolic acidosis and the risk of mortality and the prolonged stay in hospital is related to their development of AKI. Here is one of like a systemic review I found that they try to predict the patient of, who present with DKA and at risk of AKI, and they found in most of the studies probably older age of presentation, higher rate, heart rate at presentation, higher urea level at presentation, higher glucose, corrected serum sodium concentration, higher glucose concentration, and lower pH at time of initial presentation. Probably if these are there at time of patient presentation with diabetic ketoacidosis, probably this patient is at higher risk of development of AKI. And we knew that the DKA predisposed to AKI through the volume depletion and renal hypoperfusion due to the osmotic diuresis and also gastrointestinal losses, because most of these patients will present with abdominal pain and repeated vomiting and low intake. So we talk about diabetic kidney disease now. Before we go to the second part of our presentation, I would start with, like to start with the second case. Here I have a 12 years old child. She was diagnosed to have insulin-dependent diabetes mellitus. However, her autoantibodies screening was negative. She does have significant family history of diabetes, two affected adult siblings. In January, was referred to me actually in January 2023 at a stage of CKD stage 2. He has no proteinuria. So because of significant reduction, actually, at time when I see even his GFR was lower than this, he improved later. So immediately when I heard about the patient, I thought of something else rather than just diabetic kidney disease. So we go back and we trace the sibling actually genetic mutation, which revealed that the sibling, the older sibling, is identified to have hepatocyte nuclear factor 1 beta mutation, MODY type 5. So subsequently, I screened his other sibling and I identified another younger sibling. She's currently following up with me. At time of diagnosis, she was 9 years old. And at time of screening, we identified her at stage 2 CKD, but without initially no diabetes. After 2 years, she progressed and now she is diabetic. So monogenic forms of diabetes. So it represents an uncommon group of single gene disorder characterized by functional defect of pancreatic B cells. Monogenic forms of diabetes include the neonatal diabetes mellitus and maturity onset diabetes of young and mitochondrial diabetes. There are many genetic mutations that are identified to cause monogenic diabetes. Some of them are known to be associated with kidney anomalies. So we need to be aware about the presence of such condition because these patient management could be different. Maturity onset diabetes of young is clinically characterized by diabetes diagnosed at a young age less than 25 years with an autosomal dominant transmission and lack of autoantibodies. It is a heterogeneous group of disorders and it is difficult to predict unless you specifically actually look for it. That's why many of these patients ended up to be diagnosed at type 1 or type 2 diabetes. Here I present most commonly identified genes that cause maturity onset diabetes of young. And Moody type 5 is the one that is actually associated with kidney involvement. So Moody type 5, this is a former, now it is more more new terminology for it is hepatocyte nuclear factor 1 beta. Affected patients can develop many manifestations that include pancreatic atrophy, abnormal kidney development, ranging from renal dysplasia to the multiple cystic kidney and kidney hyperplasia. It is associated with a slowly progressing impairment of kidney function. Also, so that's why we need to be aware about this disorder because when we diagnose such patients, we screen them because, for example, they might have hypomagnesemia, they might have transaminitis, and also some patients might have genital abnormalities. So if we talk about the management of diabetic kidney diseases in children, we need to address the risk factors that contribute to the development of DKD. The first identified risk factor for DKD is the hyperglycemia, and the guidelines indicate that we should aim for type 1 diabetes at glycated hemoglobin level target is less than 7.5, and type 2 diabetes is actually less than, we should aim for hemoglobin A1C less than 7%. Other entity that we should address is the insulin resistant. It was previously mainly we correlated to type 2 diabetes, but also now it is prevalent in both types of diabetes. And insulin resistant has been strongly linked to the development of DKD. Insulin resistant can by itself initiate kidney injury independent or prior to the presence of hyperglycemia. That's why, as we said, we screen type 2 diabetes patients at time of presentation for any nephropathy. And insulin resistant is well known to be augmented at the growth and the hormonal changes that occur during puberty. So patients might need adjustment for their doses at this period. Hypertension, so we need to screen for it and look for it. And if we diagnose patient, we need to start antihypertensive. The preferred agent is angiotensin converting enzyme inhibitors or receptor blockers. And the guidelines recommend that to initiate medication with lifestyle measures if the blood pressure is persistently above the 95th percentile. And we should target a blood pressure of less than 90th percentile in all patients. Also, we should monitor uric acid because it is known to be associated with progression of to diabetic kidney diseases. However, current available medication did not prove to have create improvement or alteration in the disease progression. So maybe dietary management is also important. The current dietary and lifestyle intervention that it is recommended it is actually like the diabetic consultant or the endocrinologist, of course, better than me, recommending these types of dietary modification and lifestyle modification. However, like the success rate of these strategies, as we observe, continue to be limited. The people are trying now different methods. For example, in adults, they try very low energy diet, which is it was promising results in adults, but it is safety and efficacy in children yet to be examined and proved. There are many new pharmacological management that being discovered and actually now currently in practice and used in adult population, like this type of drugs listed in blue in this slide. You can read it, but many of these results is not just helpful for lowering the blood sugar and better control, leading to better glycemic control. But these drugs are proved to be beneficial, to have beneficial effect on kidney outcome. However, I don't know, you can correct me, the endocrinologist, still in children and adolescents, we are yet to benefit from this medication. And we are still limited to the insulin and metformin most of the time as the glucose lowering medication. I choose to talk about one which is actually more popular and maybe available here in Oman. Adult physicians are using it, which is the sodium glucose co-transporter 2 inhibitors. It blocks, this type of medication block sodium and glucose reuptake in the proximal tubules of the kidney, resulting in increased urinary sodium and glucose excretion, leading to improvement in the metabolic and hemodynamics parameter, including hyperglycemia, body weight, and blood pressure. It attenuates renal hyperfiltration by affecting tubular glomerular feedback mechanism. There is a cardiorenal effect that is well established and well documented in adult studies. And adult studies revealed that SGLT2 inhibitors significantly lower the risk of kidney adverse outcomes, such as sustained decline in eGFR, need for dialysis, or death from kidney cause in adults. However, maybe the drawback of it is associated with increased risk of genital infection. In the past decade, there are 4 SGLT2 inhibitors drugs that are approved in adult, and it is highly recommended for patients with type 2 diabetes and kidney disease to slow the progression to dialysis. Case 3, which is the last case, is a 12-year-old girl who was diagnosed to have the insulin-dependent diabetes mellitus. However, again, she is negative in her autoantibodies, and she had significant family history of type 2 diabetes. She had fatty liver with hyperuricemia, dyslipidemia. And in February 2024, it was her onset of nephrotic range proteinuria with intermittent episodes of gross hematuria. In March 2024, we did her renal biopsy, which showed IgA nephropathy. So non-diabetic nephropathy in diabetic patients. The prevalence of glomerular disease is unrelated to diabetes or added to the course of diabetic kidney disease in diabetic patients has been reported in the range, so it is a wide range. It is actually from 3 to 70% almost. It reflects the trend of the institution to do the kidney biopsies and their criteria for such an intervention. It is, of course, important to diagnose non-diabetic, not to mislabel the patient to have diabetic nephropathy when he has a non-diabetic nephropathy, because some diseases like IgA nephropathy, membranous glomerulonephritis would respond to immunosuppressive medication, of course, plus the other conservative measures that we use for DKD. So missing these patients will be crucial and have an adverse outcome in a patient management. Here a study, actually, as we said, diabetic nephropathy is actually just a growing attention. We don't have, many of us as a pediatric nephrology, we don't tend to see lots of patients. This study, it includes 17 patients, which is actually considered a good number of patients. And these patients underwent, they are diabetes. They are diabetic patients and underwent renal biopsy because of a criteria that indicate for it. And in this study, the outcome of their kidney biopsy or the results of kidney biopsy identified 4 patients with diabetic nephropathy and 3 patients with IgA nephropathy. And there are others. So these are the most common prevalent type of diagnosis when they do the kidney biopsies for these patients. This is an adult study, and again, in this study, IgA nephropathy was among the commonest diseases that are identified. Of course, the most common biopsy diagnosis is diabetic nephropathy, followed by FSGS, membranous nephropathy, and IgA nephropathy. Both membranous and IgA nephropathy, as we said, are treatable conditions. So in conclusion, early intervention and treatment strategies are essential to slow the progression of kidney disease in children with diabetes. We need future study to understand natural history and risk factor of diabetic kidney disease in children, and renal disease in children with diabetes are critical. Is a critical area of concern, require early detection, regular monitoring, and timely intervention to prevent progression to more severe stage of kidney disease. Thank you. That's all of my presentation.
Thank you very much, Dr. Thuraiya, for this enlightening session. We have learned a lot of things from you. So thank you very much on behalf of Oman Diabetes Association and Dr. Mariam Badi, the head of scientific committee, sending her regards and thanking you very much for your talk. I would encourage all of our audience to type their questions in the QA box, and meanwhile, I would like to remind all of our audience, first of all, I would like to thank them to stay with us until this time and attending this useful session. But we do have other useful sessions arranged by our scientific committee over the next couple of months as well. So we have an interesting topic about screening of cardiovascular complications in diabetes That's in May. And we have another session in June on 24th of June. Perhaps that's the tempting date is going to be about diabetic retinopathy and AI, artificial intelligence. That would be a very interesting topic. Right. So I'm happy to take your questions. Dr. Shakir Mahmoud is sending his thanks again to you, Dr. Threya. Let's see if there are any more questions coming through. If not, then so let me ask you this question while waiting for the others to prepare for their questions. At what age or diabetes duration would you recommend initiating the annual microalbuminuria screening? As far as I do remember from the NICE recommendation, from age of 12 onwards, then all the children live with type 1 diabetes will have the annual screening for the early morning or first void albumin-creatinine ratio. Do you still abide by this, or would you take the duration of diabetes more than 5 years and then you start screening? Which one would you recommend more?
I think the updated guidelines is to start from 5 years after the diagnosis of type 2 diabetes. And at the age of 10, so if patient is diagnosed as type 1 diabetes and he is achieving puberty or 10 years of age, we need to start, whichever is earlier, we need to start the screening for albuminuria. This is according to the updated guidelines.
Okay. Thank you very much for that. Dr. Abdul
And
Salam.
still, if you observe, like for example, sometimes you notice a delay in referral because the people thought the patient present with, for example, DKA and deranged renal function test. People would thought that, I want to highlight this because people would thought that this is just because of his acute kidney injury related to the acute presentation of DKA. However, these patients need to be monitored later on to identify their baseline creatinine because, as we say, and we see actually in our clinical practice, sometimes even like classically, the albuminuria should be present before the derangement in GFR. We do see the reverse in some patients.
Wonderful. Thank you very much. Dr. Bahar Rajab is saying thank you, Dr. Threya, and then Dr. Abdul Salam Ali thanking you again, Dr. Threya. But his question is how to predict a non-diabetic kidney disease in diabetic patients.
Yeah, so there is several criteria, but it is not an absolute, indication. So that's why a patient might end up labeled as a missed diagnosis of just diabetic kidney disease because these non-diabetic kidney diseases are sometimes difficult to predict. However, in any patient who have, especially in pediatric, who has hematuria or nephrotic range proteinuria or significant moderate to severe albuminuria, we tend to go for renal biopsy because it is rare, or patient, for example, presenting to us with a significant reduction in GFR, less than 60. So this is unusual for a pediatric population. So we tend to, as a pediatric nephrologist, we tend to screen earlier with renal biopsy compared to adults because we knew this sort of diabetic kidney diseases need time, need duration to develop, and when we see it severe at a duration, even 5 years of duration, however, it should be just still mild in usual forms. When it is already manifested as a significant abnormalities, we have a low threshold to go and screen for with renal biopsy. Of course, the presence of hematuria and we screen like so diabetic patients are like any other patient, so you should screen for the extra renal manifestation like skin rash, joint pain, as we actually tackle any other patient with suspected nephropathy. We do screen them with ultrasound also at baseline to rule out renal anomaly.
Thank you very much. Dr. Mariam Badi is asking, what are the referral criteria for diabetic patients with microalbuminuria to nephrologists? When would you like to see them?
So any patient with moderate albuminuria should be referred. Should be like moderate albuminuria, more than 30 milligram, the albumin excretion rate, more than 30 milligram per day.
Dr. Trey, can you put the slides back again so that will remind our audience about the cutoffs that you just referred to?
Yeah. So mild to moderate is the gray zone. So
Okay.
it's persistent and it is actually better to refer. You could repeat it and see in like other occasions, 2 occasions, and if it's persistent, even mild form, I believe should be bring to the attention of the nephrologist, because we might identify another form, non-diabetic nephropathy in Europe at this stage.
And when you say persistent, do you mean persistence over 3 months or 6 months?
Yeah, in 3 to 6 month period, you need to have 3 positive results. If you have the first positive result and it was random, make sure that your subsequent testing done in a proper way, first morning vote.
Okay. Perhaps that will take us to the next question from our colleague from Libya, Dr. Nadia Al-Ghazair. She's asking, saying the cutoff point of ACR has changed to 20 rather than 30 newly or recently. Is this applicable?
This is what I identified. So actually, as a nephrologist, we use so when we defined proteinuria is less than 20 milligram per millimole of protein to creatinine ratio. But this is the guidelines I identified for the albuminuria in today.
Perhaps you've already referred to if you got even mild albuminuria less than 30, but it's persistent, so it may worth bringing this case to the attention of nephrologists for possible other causes of nephropathy.
Yes, which is actually the case still most of the time, because we knew that diabetic kidney disease needs time to develop. For example, if I'm talking about Oman, because our duration for follow-up is just up to 12 years. At like 13 years, we are transferring to adults. So it's considered a short duration for a disease to cause a manifested complication. So when we do see patients with a manifestation of albuminuria or reduction in GFR, we usually look for other causes other than diabetic kidney disease. And then if that is excluded, we label it as diabetic kidney disease.
We are already 6 times over the time, so that we'll just have a last question. And thank you very much for your patience with us. Anonymous attendee asked, if a patient developed microalbuminuria and received ACE inhibitors, and the microalbuminuria improved, do we stop the ACE?
No, actually, because this improvement will be likely because of your ACE inhibitor. Your dosing of your ACE inhibitors will depend on the control. If you achieved with a small dose, you achieve a control of your albuminuria in your patient. So that is an enough dose. We don't usually stop it because we knew this is a progressive disease and patient already had the damage at the cellular level that caused this manifestation of albuminuria. With this medication, our aim to prevent the progression of the disease. So if you stop it, you are going to see back your albuminuria, and so it will be unnecessarily stopped. However, the dosing, like the continuous of monitoring of albuminuria, even if the patient is already on ACE inhibitor, is important, of course, because you will need to know if that dose, for example, is enough, or you need to do other measures to control the patient.
Right, yeah. Thank you very much, Dr. Thuraya, for joining the Oman Diabetes Association today in this educational webinar. And we appreciate all of your efforts and your nice presentation. And we hope to see you again in the future. Dear attendees, thank you very much for staying with us till this time. And you are welcome to attend our monthly scientific webinars. And thank you again for being with us. Good night, good evening, wherever you are. I wish you a nice time and thank you very much. Goodbye.
Thank you very much, Dr. Hussein, and thank you for all of the audience. Thank you.
Most welcome. Thank you.